Hello, everybody. Welcome to the PrecisCa Hematologic Malignancies Tumor Board. Very happy to have you here. Very excited to go through some of these really interesting cases. The cases that we are going to focus on today are all patients with various forms of lymphomas. We have an outstanding panel with us here today to go over these cases. I'm very excited to be amongst them. I'm going to first introduce myself. I'm Dan Pollier from the University of Colorado, and I'd like each of my colleagues to introduce themselves. Dr. Fromm, please.
Hi, my name is Tyler Fromm. I'm an assistant professor of radiology with appointments in abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri. I specialize in oncologic imaging with a focus on MRI and PET examinations.
Larry Keston. I am a radiation oncologist in Michigan, in the Detroit area. I work for Michigan Healthcare Professionals and Genesis Care USA. I'm the medical director of the Michigan region.
Hi, I'm Jeremy Abramson. I am a medical oncologist specializing in lymphoma. I direct the lymphoma program at the Massachusetts General Hospital in Boston, and am associate professor of medicine at Harvard Medical School.
John Pagel. I am the chief of hematologic malignancies and the director of the stem cell and cellular therapy program at the Swedish Cancer Institute in Seattle, Washington.
This is a 26-year-old female with stage 2B Hodgkin lymphoma with unfavorable risk features. She undergoes 4 of 6 cycles, or 4 of a planned 6 cycles of the ABVD regimen, and has a complete response on her PET scan. So we're going to talk about the optimal treatment for this patient. We're going to talk about the role for radiation. Before we jump into that, Dr. Abramson, real quick, you gave us a very nice overview of staging before, but there's this other issue with Hodgkin lymphoma, unrelated to staging of risk factors. We're told that this patient has unfavorable risk factors. Can you just briefly go through what that means in these situations?
Yeah, so risk in Hodgkin lymphoma in limited stage is really a function of evaluation by the German Hodgkin lymphoma study group, which identified a series of risk factors that would predict for unfavorable risk disease, and thus have lower cure rates with standard therapy. But I would say everything is relative, and patients with early unfavorable Hodgkin lymphoma still have extremely high cure rates with standard therapy. What are those adverse risk factors? Those have been defined as the presence of bulky disease in the mediastinum by the definitions I shared earlier. That's typically been 7.5 centimeters or above. In Europe and American trials, they've used often 10 centimeters. The presence of B symptoms. This patient has B symptoms. B symptoms are defined as drenching night sweats, presence of recurrent fevers, or loss of over 10% or more body weight over the prior 6 months. Also joining that is elevation of the erythrocyte sedimentation rate, has also been associated with adverse risk, particularly when associated with B symptoms. And then the remaining adverse risk factors are number of nodal regions. So 3 or more nodal regions has been associated with early unfavorable disease, as well as involvement of extranodal sites. So those are 4 risk factors. Any one of those 4 would qualify as early unfavorable. Absence of all of those risk factors would define as early favorable disease.
Great. Thanks for that clarification. So let's talk about how this patient presented. Left neck swelling for 1 month, as well as fevers and the unintentional weight loss. So we're seeing some of those symptoms there. But still, it's felt to have a performance status of 0. No other prior medical history for this young woman. No contributory social history issues, and a family history of some malignancy, but really unclear or limited understanding. So this patient underwent an excisional biopsy of the left cervical lymph node, which I'll point out is the preferred biopsy strategy for Hodgkin lymphoma. Maybe we'll touch on that with some of our later, but that is very important to get that excisional biopsy. And we now have an understanding that this is Hodgkin lymphoma with mixed cellularity. So Dr. Pagel before took us through the different subtypes. This is not the most common subtype of Hodgkin lymphoma, but this is also not the very indolent but incurable subtype of Hodgkin lymphoma, which we'll talk about soon. The patient was had the classic CD15, CD30 positivity, weak PAX5, and negative for CD20, which would be expected, relatively expected with this subtype, but grouped in the unfavorable category. So maybe we could, Dr. Fromm, you could take us through the imaging, please.
Sure. I can maybe just focus on the initial stage imaging. So on the left side of the screen, we have a maximum intensity projection image from an FDG PET CT scan. And essentially what this is a way of visualizing three-dimensional data in 2 dimensions to kind of get an overview of what's going on. And these sort of black lumpy areas that we see in the sort of upper chest and sort of left supraclavicular region correspond with sites of nodal involvement by lymphoma. So we definitely have multiple stations above the diaphragm involved. We see a little bit of activity in the right supraclavicular region that's a little bit more ill-defined. And we actually see on one of the transaxial fused PET CT images, the one on the top, that on the right-hand side, it's hard to tell without actually having the CT without the fusion, but that could actually just be some fat density on the CT scan, which would suggest that is actually perhaps a site of just activated brown adipose tissue, which we sometimes see on these scans, rather than an additional site of disease. And then the lower image in the middle shows some of those sites of nodal disease in the mediastinum. Another thing also to mention about the MIP image is that we don't see really any evidence of splenic involvement or nodal disease below the diaphragm, but we do sort of see this kind of diffuse pattern of mildly increased radiotracer uptake within the marrow. And some of those areas, it looks like that degree of uptake is perhaps similar to or a touch greater than the liver. This is always hard for us to interpret on these scans because we know the marrow can be a site of disease involvement by lymphoma, but there are other things that can cause this radiotracer to be taken up in the marrow as well. So patients who have some sort of cytopenia like anemia, you can kind of see a reactive increase in the amount of uptake that goes into the marrow. So I'm not sure if this patient had a bone marrow biopsy, but it would be certainly something that would raise the possibility for when interpreting the scan.
So that's a great point. Dr. Pagel, is this a patient you would get a bone marrow biopsy to stage at diagnosis?
It's a really good question. The question actually is a bit controversial, to be honest. In the more recent past, we would have probably routinely always gotten a biopsy of the bone marrow in this kind of patient, just to make sure that we had accurate and complete staging. Of course, you never really know what's in the marrow until you take a look. However, we do a really good job of understanding what the marrow often looks like by these PET scans. These PET scans without focal or significant uptake on marrow space really suggest to us that the marrow is not involved. And in someone with this kind of presentation where they have disease just above the diaphragm, this is really what we're looking at stage 2 disease, it's highly unlikely that this patient would have marrow involvement. I would not do a bone marrow biopsy on a patient like this. I won't speak for Dr. Abramson. I wouldn't fault him, of course, if he told me he wanted to do marrow here, but if I had to guess, my hunch is he wouldn't do a marrow either. It would be highly unlikely to be involved with this kind of PET scan.
Yeah, I agree. I also wouldn't do a bone marrow. And it's worth noting that Hodgkin lymphoma is often a very inflammatory condition. And we know that in this particular patient because they're having these systemic B symptoms of fevers. I anticipate their erythrocyte sedimentation rate is also elevated. That the patient with B symptoms does have the release of these inflammatory chemicals called cytokines that often leads to this diffuse, mild uptake within the bone marrow, which actually looks very different than bone marrow involvement by Hodgkin lymphoma, which is virtually never uniform throughout, but rather patchy in location. And so had we seen very bright patchy areas within the marrow, that would have raised suspicion. This mild diffuse uptake to me suggests an inflammatory reaction within the marrow. And I think that's consistent with Dr. Fromm was describing.
Great.
Yeah, there are some cases certainly where, you know, the marrow activity looks totally normal, where we say clearly there's no involvement. In some cases where we can say yes, you know, especially if it's if the marrow is like, you know, substantially above the liver, or it's sort of patchy, heterogeneous, then you feel very confident that it is involved. There are unfortunately some cases that are kind of borderline, you know, that we can't really make that call clearly based on the imaging alone. And I think some of the clinical, you know, features of the disease and the oncologist's sort of clinical judgment, you know, go into that decision as to whether to chase that lead down further or not.
Thanks. Thank you for that. So we have a young woman with early stage, unfavorable risk, Hodgkin with mixed cellularity, and she has now gotten 4 cycles of ABVD with an interim PET and a plan for 2 more cycles. Dr. Abramson, how would you have treated this patient? Is this are there any differences in that you would have taken in your approach?
So, and to clarify, are we seeing, these are all baseline images right now, not interim images, right?
I believe this is after cycle 4, and I was going to ask you if that is if it's your practice to do a post cycle 4 imaging, or if you do that early.
I see. Yeah, we usually do interim PET scans after cycle 2 in classical Hodgkin lymphoma. The projected image on the far right here looks terrific. This looks like a very good response to therapy. In general, patients with early unfavorable and disease with B symptoms, we'll often treat patients with 2B disease similar as we would treat a patient with stage 3 or 4 disease. That would typically be with 6 cycles of ABVD. And so this is a patient who, for stage 2B disease up front, early unfavorable, a lot of nodal disease above the diaphragm, I would generally be planning for 6 total cycles of therapy. The other thing that will extrapolate from advanced stage disease is whether we continue the bleomycin for all 6 cycles. We have a clinical trial called the RAFL trial, which was performed in Europe, that took patients and stratified them based on the interim PET scan. This was done after 2 cycles. Patients who had an interim complete remission after cycle 2 were randomized to continue the ABVD in full, or to discontinue the bleomycin and continue the adriamycin via vinblastine and dacarbazine. What that trial found is there was identical cure rate for the patients who had the bleomycin discontinued and less toxicity, including hematologic and pulmonary toxicity. So my practice in stage 2B or in advanced stage Hodgkin lymphoma, if I'm using traditional ABVD, is to do a PET scan, and if they're still if they're PET negative after 2 cycles, meaning a Deauville score of 1 to 3, I'll drop the bleomycin and continue AVD for the remaining cycles. I think I saw on the slide that this patient had a Deauville 4 on their interim, and that this was done after cycle 4 and not cycle 2. So it's a little harder to know. Wait, no, this was PET. Okay, the interim PET scan was done after 2 cycles, and they were in a partial response, not a complete response. This becomes a bit more. And I see. I'm following. They also got a PET scan after 4 cycles, and were in a complete metabolic remission at that time, and now in a Deauville 2. So in this patient, I would continue. I probably would have continued the bleomycin because they didn't achieve an early PET CR at cycle 2, but would complete 6 total cycles of ABVD in this patient. And for limited stage disease patients who achieve a complete remission, I usually do not consolidate with radiation therapy, but that would certainly be an option.
So that was going to be my next question for Dr. Keston, to just see if he had any thoughts on radiation. But just real quick before that, not to beat the bone marrow biopsy horse too much, but it seems as if even if you had done a bone marrow biopsy and you had found that this patient had involvement and you had stage care as a stage 4, your plan of 6 cycles of ABVD wouldn't have changed. Is that?
That's correct.
Yeah. So another reason in this case,
Yeah.
bone marrow biopsy wouldn't have been really helpful.
Yeah,
Yeah.
Dr. Pollier, I might add a little bit to, Dr. Abramson's discussion. I completely agree with his approach. Again, just to summarize that is with an unfavorable stage 2 disease, you either can do a PET adapted or not a PET adapted approach based on a PET scan after 2 cycles. His understanding, though, of already here knowing that a PET scan after 4 cycles was negative really does influence the idea that, he would have continued with ABVD. However, often we're faced with that PET scan after 2 cycles and haven't gotten to 4 cycles yet. So this one would have been counted as a positive PET scan after 2 cycles. And if you look at that RAPL trial, which Dr. Abramson alluded to, a very important trial that really sets the stage for how to treat these patients, it was designed for those patients who have PET2 positive disease to actually have an escalation of their therapy, to actually go to a very intense regimen that's often very hard to deliver to many patients, which we call escalated BIACOP. This is an interesting example of those patients who may have a PET2 positive scan, who we might have treated with a very aggressive regimen, who might not have even needed it. I like the idea that this patient didn't get escalated BIACOP and now has still achieved a negative PET after another 2 cycles of whatever they got. I don't think we've described if the bleomycin was removed or not, but do understand that there is, of course, there are those patients who have positive PET2 scans where we are really not sure exactly how to treat them, even though that trial and the standard is to go to a more escalated therapy. I think it's also important, and Dr. Fromm certainly would be critically important to weigh in here as well, in that Deauville-4 scores can be very heterogeneous, so to speak, in their description. Certainly, if you're going from a SUV or a standard uptake value of 25 down to, let's say, a level of 4, it was almost to the uptake in liver, then that's a very different story than someone who has a Deauville-5 score with new evidence of disease or clear, obvious progressive disease. So in someone who may have had a Deauville-4, things are getting significantly better. Even though we would have called that a PET2 positive scan, I probably wouldn't have, my own practice, gone to escalated BIACOP. I would have probably continued with ABVD, kept the bleo in, just like Dr. Abramson said he probably would have. Again, even now in retrospect, knowing that this patient got a metabolic complete remission after the PET scan and four total cycles at that point.
Yeah, I think the interim PET positive patients are a challenge in the sense that we have randomized data on what happens if they're interim PET negative, but the data based on interim PET positive are non-randomized. We don't really know if intensifying is doing better for all of those patients or only in a subset. Because as Dr. Pagel points out, there's PET positive and then there's PET positive. There's PET positive that's significantly brighter than the liver and maybe only a mild decrement in size. And then there's clearly a dramatic response that remains just a tiny bit brighter than the liver and is therefore called Deauville-4. But when you look at it, you see that is a dramatic response. And I have to say, that's the majority in my experience of interim PET positive patients. They're clearly responding well. This is a highly chemosensitive disease, and I continue their therapy. For those patients who are clearly not responding well, those PET positive patients, I do intensify those patients, but I don't think this is an area where we can really do a one-size-fits-all approach. And I think it's really an important area where I find looking at the imaging myself, talking and collaborating with my my radiology colleagues, and really assessing the quality of response is important in deciding the way forward. The other important point is that for those patients who truly did have brightly interim PET positive disease, I'm much likelier to include consolidated radiation therapy at the end of treatment for those patients, since they are showing signs of being less chemotherapy sensitive.
Yeah, so that I just wanted to reinforce Dr. Pagel's point about, the importance of that decision to escalate for a 26-year-old, patient, and just the fertility implications of that are really important to be very, very thoughtful about that. But Dr. Keston, following up on what Dr. Abramson just told us, would you be pushed to argue with a medical oncologist who says that we're doing 6 cycles of ABVD and we're done in a patient such as this who has unfavorable risk features, early stage, but didn't have an interim negative PET? Do you think it would be really important to push for consolidated radiotherapy?
Well, so first of all, for this particular case, there are 2 standard options, right? One is the 6 cycles of ABVD, as has been discussed, and the second would be 4 cycles of ABVD followed by involved site radiation therapy. And in general, when one is deciding between those 2, we try to choose the less toxic regimen. And of course, there's some physician preference and other, biases that are involved. But in general, the cure rates are the same. The toxicities can obviously be different. In some settings, one may wish to give radiation treatment to that localized site versus giving 2 additional cycles. Some of the things that influence that decision would be, why is it an unfavorable case? Are there B symptoms, which there were in this case? Was there an elevated sedimentation rate? Those are things that would lead you more toward adding additional cycles of chemotherapy and not giving radiation treatment. If it's bulky disease, then one might be more inclined to add radiation treatment or even give the full chemotherapy course and add radiation treatment. So we try to choose the less toxic regimen. And I certainly agree with Dr. Abramson and Dr. Pagel in this particular case that I would not typically recommend radiation treatment for this case, except in certain circumstances. So, such as not having a metabolic complete response, as occurred in this patient was fortunate enough to have. Getting back to the bulky disease issue, I would not consider this bulky disease. Bulky disease has been a bit nebulous and certainly evolving term over the years. And classically for Hodgkin's lymphoma, as has been stated by both medical oncologists, the definition is a tumor size, a maximum tumor dimension greater than 10 centimeters, which is not always the most applicable definition. There are some more recent studies that look at things like total metabolic tumor volume or metabolic bulk volume, and take the largest area of uptake on the PET and measure that in terms of CCs. In this particular instance, although this is kind of, if you're looking at that image on the left there of the PET scan, it's a relatively larger area of involvement, but these are multiple small lymph nodes distributed over a large area, bilateral supraclavicular, bilateral mediastinal. And so I would not consider this classic bulky disease personally. And also because of the distribution, if one were to give radiation treatment, involved site radiation treatment for this case, we would have to cover all of those areas, right? So, and so the side effects of radiation treatment, again, are, only where the x-rays are aimed. But in this particular instance, that could be a little more difficult regimen due to, again, the thyroid, more so the esophagus, and even more so the lungs, and this seems to be almost entirely superior to the heart, but certainly, heart toxicity can come into play with radiation treatment at times. And in this patient, this is a 26-year-old female. And as you can see in the, hopefully you can see in the lower image there in the middle, the breasts are right at that level. And therefore would receive some radiation therapy dose, no matter what technique you used. And many studies have shown that over time, often 15, 20, 30 years later, but over time, giving radiation treatment in this setting increases the risk of subsequent development of breast cancer. So, for all the reasons that have been described already, it's certainly reasonable to give 6 cycles of ABVD, as was discussed anyway. But this would be a case because of the number of tiny lymph nodes, the distribution, the fact that it was B symptoms, the fact that it was not bulky disease, a 26-year-old female with the breast in that location. I would not lean toward radiation treatment.
That's great. Thank you so much. So I think, we've answered these major questions. I think, for me, the take-home points here are primarily, that the early stage unfavorable risk patient such as this wouldn't have much benefit from a bone marrow biopsy for staging for 2 reasons. 1, because of the relatively low likelihood of involvement, and 2, because it wouldn't change therapy. I think, there seems to be consensus on a prescribed course of ABVD with an early interim PET CT. A positive interim PET CT presents challenges because of relative lack of data, but strategies could include escalating therapy or continuing bleomycin versus stopping the bleomycin and continuing the course of the ABVD if the interim PET CT were to be negative. And again, I think it's very important to recognize this is a patient for whom cure is the goal.